Committee to order. Will the Secretary please call the roll?
Director Kim, Director Sorrell,
Present.
Director Staines,
Here.
Chair Bott is absent, and I apologize, Acting Chair Sorrell.
Okay.
You do have a quorum.
All right, thank you. And the next regular meeting of the committee is scheduled for Friday, June 12th at 9 a.m. All right. Do we have anyone joining remotely at this time?
We do not have any members joined remotely.
Okay. The next item is public testimony. As a reminder, written testimony will not be read into the record, but will be included in the official record and posted on the website. Madam Secretary, do we have any speakers who registered to provide in-person or virtual oral testimony or submitted written testimony?
We do not.
Okay, thank you. All right, Dr. Lauren Smith will now review the proposed reappointments to Stroger Hospital and the department and division chairs. Good morning.
Good morning. Dr. Lauren Smith, Chief Medical Officer. This morning I have three requests for approvals for you. The first is for Dr. Mallory Williams for reappointment for Chair of the Department of Trauma and Burn. Dr. Williams attended the University of Maryland School of Medicine. He did his training at Wayne State University in general surgery with an NIH research fellowship. And then he also did a surgical critical care fellowship in clinical instructor of trauma, burn, and critical care at Brigham and Women's Hospital. He first joined Cook County in April of 2024. And this would be for a 2-year term running from May 1st, 2026 through May 31st, 2026. I'm sorry, 28. The next would be for approval for reappointment for the Division of Vascular Surgery under the Department of Surgery for Dr. Erin Farlow. Dr. Erin Farlow completed medical school at Washington University. She did her general surgery training at Rush University and a vascular surgery fellowship at Indiana University School of Medicine. She first joined CCH in 2014. She was initially appointed chair in 2019. So this would be for a renewal of a 2-year term running from May 1st, 2026 through May 31st, 2028. And the last request for approval for reappointment is for the Division of Urology under the Department of Surgery, Dr. Courtney Hollowell. He attended University of Illinois College of Medicine and did his training for general surgery as well as urology and urological oncology at the University of Chicago. He initially joined Cook County in 2002, was initially appointed division chair in May 2008, and this would be for a 2-year term renewing May 1st, 2026, running through May 31st, 2028. So we're respectfully requesting approval for those 3 individuals.
Thank you.
I move approval. Need a motion?
So we have to move and second. I'm sorry, did I hear a second? Okay. So we have moved and second. Any discussion on the motion? All in favor?
Aye.
All opposed? Okay. Then the ayes have it. Motion carries. And then Dr. Joseph Palter will be subbing for Dr. Patrianikis from Stroger EMS President
Good morning.
to present his report.
I'm Dr. Palter. I'm one of the treasurers for the executive medical staff here at Stroger. Nice to see you all. Dr. Patrianikis apologizes for not being able to make it today, and I'm going to provide the update. The EMS has been working on a few things. One, we're continuing to update the credentialing policy to create a unified combined credentialing group for both Stroger and Provident that will help streamline the process in terms of getting physicians and kind of creating better alignment between the 2 groups. In addition, we're also continuing to work on the bylaws with our administration to update them, specifically the peer review process, among many other things that we'd like to update and improve upon to better operate as an executive medical staff.
And then Dr. Paul Allegretti, Provident Hospital MEC President, had a conflict and wasn't able to attend today. But the Provident medical staff action items were sent in advance of the meeting to be presented for the committee's consideration. Is that what these are? Okay. All right. Then I'd like to entertain a motion then to approve item 3B, the Stroger Hospital and Provident Hospital medical appointments, reappointments, and changes. So will someone make that motion?
So moved. Second.
All right, moved in second. Any discussion on the motion? All in favor? Aye. All opposed? All right, the motion carries. Okay, the minutes for the April 17th, thank you. The minutes for the April 17th committee meeting were approved by the board in April, but they're being presented today for the committee's acceptance. Are there any corrections or revisions needed to be made to the minutes? Any information? Okay. I'd like to entertain the motion to accept item 3C, the Quality and Patient Safety Committee meeting minutes of April 17th, 2026.
So moved. Second.
All right. And I heard someone online.
And for the record, Director Harrington has joined us, for informational purposes. He's not a voting member, so we don't need a motion.
Okay, thank you. All right. So we have made it first and second. Any discussion on the motion? No. All right. All in favor?
Aye.
And all opposed? So the motion carries. The ayes have it. The next item is a county care accreditation matter, which will be reviewed by Cindy San Miguel, Director of Health Equity for the Health Plan Services. Cindy? Good morning.
Hi, good morning, everyone. My name is Cindy San Miguel. I use she, her, ella pronouns, and I'm the Director of Health Equity at County Care. So today I'll speak to you a little bit about our culture, humility, and culturally linguistically appropriate services program description. So in this brief presentation, I'll give you an overview of the County Care accreditation, explain to you what we need from you all from the Health Equity accreditation. I'll give you a high-level synopsis of our cultural humility and culturally linguistically appropriate services program description and talk about next steps. So as you all know, County Care has the NCQA accreditation. We are a 4-star health plan. In this slide, we just give you an overview of why we pursue this accreditation. It helps us have a rigorous level of quality and have high level of standards for the care that we provide to our members. In addition, we are now pursuing the Health Equity accreditation, and this is just going to help us further our commitment to reducing health disparities and ensuring equitable care for all of our members. The reason that this is important is that, one, I think, as you all know, we have had a long-standing commitment to reducing healthcare disparities, but in addition, this is also required by HFS and this new cycle of the contract that we're, anxiously awaiting to receive news on. Next slide, please. This gives you an understanding of our timeline. We did apply for the Health Equity accreditation in September of last year. We have a look-back period where we'll be gathering and reviewing all of our evidence between December of 2025 through June of 2026. Our plan is to submit all of our materials by June 22nd and then receive the NCQA decision by the end of July. So there's lots of goodies in this accreditation. This has really provided us a roadmap to see how are we kind of, performing in terms of health equity, and helped us understand what are some potential gaps so that we can just further that commitment. One particular element is element number 5, this focus on culturally and linguistically appropriate services programs. So we need to develop a program description. We need to include a number of different items in here that show how our health plan is ensuring that we're providing these services. And ultimately, we need a approval by the governing body, which is why we're presenting this to you all today. In the next slide, This gives you a sense of what we put into this plan. So it really summarizes County Care's completed and ongoing activities related to culturally linguistically appropriate services. I'll use the acronym CLASS moving forward. We also talk about our activities related to cultural humility, health equity, and the social determinants of health. The plan itself is organized by the 15 CLASS standards put forth by the U.S. Department of Health and Human Services, and really focuses on quality of care and elimination of healthcare disparities. So on the next slide, if you're not as familiar with the 15 CLASS standards, this is the way that we organize the topics and the content covered for just kind of help us interpret and organize how these activities will impact the health plan. So under operations, you have oversight, governance of the CLASS PD. We also talk about our efforts with workforce development, trainings, and grievances. Under the social determinants of health section, we have quite a bit of activities related to housing, food access, and language access. There's lots of focus on language access in this particular program description. And then there's a number of activities and objectives related to special populations, including our justice-involved members and maternal and child health populations. So all of this is cohesively working towards improving quality and reducing healthcare disparities. Then on the next slide, you see a just highlight of the types of activities and objectives that are going to drive this work forward. So in operations, I know this is a little small, but it's, we convene our community partners to ensure program description is community informed. So that participatory approach is absolutely critical. We have a number of trainings on cultural humanities for our providers, our staff, and our vendors. We track member grievances by race, ethnicity, and language, and respond accordingly to see if there's any trends. We're also going to ensure that the diversity of our staff is reflective of the communities that we serve as well. Under social determinants of health, we are looking to identify members who are housing insecure and connect them to housing resources within Cook County. We have objectives related to looking at our food care program and understanding of the members that are eligible, who's connected to what programs, including emergency meals, medically tailored meals, and telenutrition visits. We are also ensuring that non-English speaking members and members with disabilities receive communications in their preferred language or method. And we've developed a number of different training materials for our staff and our providers on how to improve language access. And just a little shout out to Commissioner Morita and her Language Access Summit. We've leveraged a lot of the resources that she's put together for from that particular summit. For special populations, we have a number of goals related to our justice involved or our JI members. So we're hoping to reduce recidivism by connecting to community resources. We're also looking to connect our JI members to care coordination and use that as a lever to be able to improve access to primary care. We're also looking to a number of health outcomes related to our MCH populations. So we are looking to increase utilization of doulas and lactation consultants among our Black and African American members. And for members with hypertension, we hope to reduce the disparity in controlled blood pressure between Black and African American members and our white members. So in conclusion, we are requesting formal approval of the Cultural Humility and Culturally Linguistically Appropriate Services Program description from the Quality and Patient Safety Committee. This will bring County Care one step closer to achieving the health equity accreditation from the National Committee for Quality Assurance.
Is it okay to ask questions, Deb? Can I ask
Oh,
a question?
sure.
Just, is this the first time we've sought this accreditation?
I'm sorry.
Is this the first time we've sought this accreditation?
Correct?
I'm thrilled we are. That's great. And I know we're already doing all this work, so it's great to have it all put together this way and get recognized for it. So thank you.
Absolutely. It's a way for us to codify all the wonderful work that's already been happening.
But I do have a question about your SDOH housing, language and food, and also special population groups. Where are these requirements coming from? Is it NCQA or is it internal decision that you decided to focus on justice involved in maternal?
Yeah, so some of it is coming from the accreditation, but it's high alignment with what is also expected us from HFS as well. So as we're going through contract preparations, there is specific language and a definition for SDOH that we're trying to follow closely, and they do specifically call out housing and food. And then for special populations, these are group populations that have emerged as, you know, having potential like worse access to some of the resources that we have. Specifically, we look at the HEDIS performance and we see, okay, if we're consistently seeing worse outcomes for our JI members, then we should prioritize them and take that health equity approach. And so similarly with our maternal child health outcomes, as we look at starting prenatal care in the first trimester, starting postpartum, getting that postpartum visit and that 12 visits, if we're seeing, you know, what we say like worse performance, which really means, you know, access to care, or, you know, worse access to care and other issues, then it kind of elevates it as a priority population.
So are you saying that you picked justice involved in maternal populations as the most vulnerable among our patients? Is that what you're saying?
Most vulnerable amongst the county care memberships.
Thank you.
Thank you.
And are there other identifiers or other groups that you've identified as having specific need as part of this process that you'll be able to more highly focus on, or to be able to provide additional assistance for?
Yeah, that's a great question. So one of the activities that we did as part of this accreditation is that we looked at a number of different HEDIS metrics that were identified in the accreditation. So it was like blood pressure, it was like well-child visit, and I apologize that I can't recall the other ones off the top of my head, but there was like 5 or 6 measures, glycemic control as well. And then we did analysis on race, ethnicity, and language. And then we did review those data with our enrollees, with our community stakeholder committee, and we went through a prioritization exercise. What we consistently saw was that our Black or African American members had worse outcomes in terms of accessing care compared to our other memberships. So that really became one of the priority populations. And then from there, we as we presented to these committees, we asked them, what do you think should be the prioritization or any type of particular measure we should focus on? So that blood pressure control, that came from our members. That was an enrollee advisory committee. Focusing in on the maternal child health populations, that came from our community stakeholder committee that's comprised of community-based organizations and social service providers throughout the Cook County.
Okay, thank you.
Could you say a little bit more about what you mean by cultural humility? Because I don't maybe I just don't understand, but, you know, in your presentation, like I'm trying to figure out what this cultural humility program particularly is.
Absolutely. So County Care has really adopted cultural humility as a step further from cultural competency. And so we've developed, and when we talk about the trainings that we specifically developed, they're really more in alignment with cultural humility. The reason for that is that we strongly believe that when you're thinking about how do you connect with individuals from diverse communities, there is a humility that needs to come with that. It's a lifelong commitment to understanding that we all bring subjectivity and bias to the work that we do. And I particularly as a woman of color, as a person that's an immigrant, feel invited to the conversation to say, I also have work to do. So I don't speak for all Latinas, I don't speak for all folks that are immigrants, and it's my responsibility to connect with the communities that we serve. So all of our trainings are in alignment with the concept of cultural humility as a further commitment to how do we connect with the community. So that's the trainings that we put together for our vendors, for our provider network, and for our staff are in alignment with cultural humility.
Any more questions?
I look forward to seeing how we measure up on meeting the goals. And I've been looking through all the appendix here and glad to see so much of them are measurable, and I look forward to seeing our progress on it. Really, thank you.
Okay. And then I'd like to entertain a motion to approve the item 3D, the cultural humility and cultural appropriately services class program.
I move approval.
Second.
All right, it's been moved and seconded. Any discussion on the motion? All in favor?
Aye.
Aye.
All opposed? All right, the ayes have it. Thank you so much for the presentation. We look forward to hearing more from you. Next, the next item is the grievance and patient experience report, which will be reviewed by Ling Dong, Chief Experience Officer. Good morning.
Good morning, Chief Experience Officer. Thank you for the opportunity to present today. As a reminder, beginning in, sorry. Is that better? Is that better? Okay, thank you. Beginning, in fall of 2025, CMS requires that we, report out all of our grievance performance to our governing boards, and so this is why we're reporting the grievance report to you. So today's presentation summarizes Cook County fiscal year 2026 patient relations and grievance performance across the last 6 months. So I'll begin with an overview of our total cases, activities, and trends. This slide here shows you that if you notice that there's an increase in January, this is because we actually hired 2 new patient guest reps during this time, so they were able to help take on the real-time grievances and complaints. And not only that, we also have a presence in Providence with the patient guest rep as well. So the more accessible we are to our patients, the more opportunity it is for us to identify concerns and complaints. Next slide, please. Here we have the slides of distribution by facility. And again, this is from November 2025 all the way to April, the end of April 2026. As expected, Stroger Hospital accounts for the majority of the report, giving the scales and the complexity of our division. So what is encouraging is that we are building a stronger culture of listening across our organization, regardless of the facility size. Next, I'd like to briefly explain the different types of cases we manage. We have our compliments, we have our grievances, our complaints, and our concerns. The difference between the complaints is that when a patient comes to us and has an issue that they need resolved, and we were able to handle it real time before they leave our campus. A grievance is they left our campus, they thought about it, they're still mad about it, and then they'll either call us, or write it on social media. That's all considered a grievance. A concern for us, we have examples of concerns such as the parking, they lost their ticket, so we're helping them with their ticket. Assisting them to reconnect with the clinic, or helping them with the medication refill, and just any clarification about their discharge instruction. So that's concerns. And the great thing here is we had more concerns than we did complaints or grievances. So while many concerns are resolved quickly, we continue to monitor formal grievances trends closely. So the next slide will share with you the top 5 frequently reported concerns. Behavior and respect remains our largest opportunity area. We tried rolling out the CI Care. We improved, but now we are shifting from CI Care going towards the basics of always behaviors, right? Always be kind, always be considerate, and always be connected. Those are 3 simple steps that we just need to think about doing it all the time. We're hoping that this will sustain the standards of behavior and will help us improve on our agreements on behavior and respect. Some of the improvement actions that we've taken for these top 5, we've expanded leader rounding and real-time coaching during service recovery events. We're integrating always behavior into the performance evaluation and onboarding. We're still working on the training, but we want always behavior to be at the top of everyone's mind. And then for quality of care, We have improved interdisciplinary communication during transitions of care, increased escalation pathways for patients and unresolved clinical concerns, delay in response time. We're working with performance improvement to figure out ways on how we can actually help move the patient through, and also evaluating staffing and workflow bottlenecks in high volume departments. Communications, that's just something that we need to remind our staff that the patients, even if they have to wait a long time, as long as we communicate how long they're going to wait, it'll be a lot easier for their patient experience. Okay, so while these categories represent opportunities, our regulatory performance metrics remain strong. Next slide.
Excuse me just a second, Lee.
Yeah.
Director Harrington has a question.
Oh, yes, Director Harrington.
Yeah, what period of time are you talking about for the last two slides? You talk about the grievance date. Is this a month, a year?
November 1, 2025 through April 30th, 2026. So the last 6 months. Yeah, thank you.
That's thank you.
All right, so here, we're very pleased to report that we are great at being compliant with CMS grievance resolution requirements. CMS requires that we respond to a grievance within 7 days with a written letter, acknowledgement letter, and then also the grievance closure within 30 days. So here we're sharing with you the closure of the grievances. We usually meet or exceed the expectation of CMS by 97% rather than 80% most of the month. Like the lowest we've gotten was maybe 92%, but we only need to surpass 80. So we're doing great there. Next slide, please. Okay, so this slide highlights examples of grievances by care areas. Some of the common themes we have, especially for the ED, is just experiencing high case volume due to the nature of unplanned care and continuous operations, right? And there's another slide later I'll share about unplanned care or unplanned admission. So some of the common themes are extended wait times, communication frustrations, difficult reaching clinics or perceived staff dismissiveness, concerns regarding discharge coordination. Like for the ED, for some specific ones are just, paperwork needed or pharmacy delays, 10-hour wait time. And then like for the GMC, some examples there are patient needing medical clearance. They felt that some of the staff might be rude and unprofessional. And again, needing refills. Next slide, please. Okay, so in addition to grievance management, we are encouraged by long-term trend data. Here you will see the case volumes for the last 3 years. As you notice, the cases have gone down, even though we have had the same amount of patient guest reps to handle the cases. This is encouraging because it shows us that the patient experience initiatives are making a measurable impact across the organization. Some of the contributions were just monthly standards of behavior training, new hire onboarding education. We have open office hours for coaching and reinforcement, and also leadership rounds. We would go out and figure out what's going on, what's working well, and what's not working well, and bringing it back to the leaders to help with the improvement. In addition to concerns and grievances, we also actively capture positive patient feedback. So next slide, please. Here are some of the compliments that we've gotten. I'm not going to read through them, but, you know, these stories reinforce the dedication of our teams and help strengthen the morale and recognition. This is also the opportunity where our CEO would write a thank you letter to some of the staff members who were mentioned, and then the letters will be mailed to their homes so that their families could also appreciate and see what a great job their family members are doing. Next slide, please.
Ling, are those total cases, are those all of them, the concerns, the complaints, the grievances, and the compliments, are those all together? Is that the trend that's going down, or?
So the slides, yes, that's all, yes.
That's all, that's
Total
the
cases.
total cases, okay.
Yeah. Yes. And then, okay, so this is just being pulled from our Press Amy survey, sharing with you some of the direct patient comments. Most of them are positive. Our patients really do love our staff members, the doctors and the nurses, and I just wanted to be able to share with you that though because the patient relation is known as the complaint center, we're sharing with you some of the complaints, but truly we do have some really good news to share. Next slide. So this is an analysis compared to patient experience scores between planned and unplanned admissions. This one is for Stroger. Press Amy has done some research, and they realized that when a patient is admitted, not knowing that they're going to be admitted, they tend to give you a lower score compared to when they know they're being admitted. So this is just to share with you to see, and possibly asking the board members, you know, this is a project we're going to take to the PFAC, the Patient Family Advisory Council, but also maybe the board members might have any other suggestions for us to alleviate some of the unplanned admission, how we can make things better. But there were some ideas that were explored in asking our patients as to what concerns they have that we can't handle. Like maybe they're worried about their dogs at home that they need to feed, or they had a hair appointment they need to cancel. So just a few things that we're doing, but maybe the board members might have other suggestions to help us.
Can you break this out by readmissions versus just unplanned admissions?
Yeah, we could ask.
Because that's really critical, because oftentimes people are readmitted when, you know, the discharge information, or they're sent to a short-term care nursing home unit, which has a 40% readmission rate in Illinois. So again, I think those are issues that would be helpful to dig into.
Thank you, that's a great idea. I'll make sure to be able to present that next time. And this is for Provident. As you can see, some of them, because Provident has smaller sample size, we don't have that comparison in a few of those columns. Next slide, please. So we're very excited to share with you that we have brought back the Volunteer Resources Department. During the pandemic, it was paused, and now we're able to stand it back up. And here are just some of the information that, with the different locations and some data to share. And the next slide, I will close out with several employee engagement and cultural initiatives that are currently underway. So here, we're excited that we're launching a poetry program to focus on wellness and emotional expression. This, at other hospitals I've seen, they use poetry programs with clinicians to help them be better at communicating, visualizing, being better at diagnostic as well. So this is a new program that we'd like to showcase, and also be able to allow our patients to be able to read some of the poems while they're in the long wait areas. And we're hosting our second annual employee art exhibit. This is being launched in July, as well as expanding the Cheers for Peers recognition. And then we have another mural that we're working on for Bronzeville. They've done research showing that when the location is beautiful, people tend to feel safer and they want to visit it more. So our goal is to keep our buildings beautiful. And always behavior. This is something that's very important. We want all our employees, every single one of us, to make sure that we treat each other and our patients with kindness, consideration, and being connected with them. And then our employee engagement survey, we're launching it mid-June, June 15th through July 15th. That's about 4 weeks. Survey, as a reminder, our last one we had, it was in 2024. So it's every 2 years, so 2022 and 2024. The scores for 2024 was 3.84. It improved 3 times what was considered significant compared to 2022. And the response rate improved last year, for 2024, was at 57%, compared to 2022 was at 48%. So our goal for this year is actually to improve the engagement score at least 0.08. That's considered significant. And then to achieve a 70% response rate, stretching at 80%. So we know that engaged employees are essential to delivering compassionate, high-quality care, and that's what we're committed to do. With that, we appreciate the board's continued partnership and welcome any guidance or feedback.
I have a question about the breakdown of grievance locations that you have. There are a lot of nursing, bars there, like a third of locations, labeled as nursing. So I'm just curious, do you know what, is it just that, grievance coming out of, something happened in nursing station, or is it something to do with nursing care?
No, it's the station. It's the station. Yeah. So, like you're saying, 6 West nursing.
Yeah.
Yeah. So it's really the station. Sometimes it's not the nurse itself, but let me pull it up and see some of the examples that we had. Like nursing 6 South. One of the patients was upset with his discharge papers. That one of the nurses didn't answer the car lights. There was lost personal items. Yeah, so it's not just a nurse.
I think that's great to know, because it's just the nursing. So,
yeah, we should just name it. It's because it's press gaming. We could rename it and just say 6 East or like that instead of nursing 6 East.
So just a point of clarification, if I could. But Dr. Dan McCormick, I'm the Chief Clinical Officer. So I think you might be asking, is this an EVS complaint? Is this something about the environment of care? Is the room dirty? It's not necessarily under the control of the nurse, but certainly has the influence of the nurses, right? But yeah, so I think they're asking more of the domain, and where is it located is great, but we need to know, is this an EVS complaint, et cetera? Okay, thank you.
That way you can hone in what types of interventions might be more
And we don't want to
appropriate.
always say it's nursing that's driving the problems.
Yeah.
But the location or the crux points for some of these issues might occur more where there's a nursing counterpoint.
Correct.
Great, thank you. Any others? Okay, thank you.
I'm glad to hear the volunteer resources. We recognize that some of those activities may not appear initially to be related, but the way that rating poetry, rating some of the art involved in it, and the very well established art in terms of medicine and nursing to begin with has always been a consistent piece of following along with. So making sure that we're allowing for that and including that is going to be, I think, important as well too. So I'm glad that we've been able to bring that back. So thank you very much for being able to draw back on on that history to be able to continue that.
And just one question, if we could have a presentation or report back on the PFAC, because the PFACs, I know are being required, in quotes, required, but they can be very valuable, especially if you get the right complement of patients, families, and caregivers on the committee. And the patient families and caregivers are the majority rather than staff. Exactly. So yeah, the next time I'll give you a total report out of that PFAS. Yes. Yeah. Thank you. Great. Thank you.
Then, if that was all related to that, will we now hear about the patient, community, and member experience data and other updates?
Good morning.
Good morning.
Donica Austin Cathy, Chief Hospital Executive for Stroger. Thank you for the opportunity to share we have a newly formatted dashboard to really look at the work that's being done in our patient experience work group. And this work comes out of our Stroger Medicine Council. So before us, really the target, and this has really been a rapid improvement cycle. We're really focused on the physician and nurse communication scores. We have two targets before us to improve our physician communication domain to the top box of 85.1 and improve the nursing communication domain to 77.7. So a few things that were mentioned by Ms. Dang. And so some of the key drivers are certainly going to be including the consistent and meaningful rounds that are happening on the nurse units. Also the standardized behaviors that are always kind, always connected, always considerate, and then increasing the physician awareness and adoption of really best practices, and making sure that every physician, even our residents as they onboard, understand the expectations in terms of physician communication with our patients. A few things that the nurse leaders are doing, they are continuing to focus on the I-rounds, targeting patients. Also, there's focused audits on consistent communication behaviors, as described earlier. Also, we're doing real-time coaching with the staff, because there are sometimes not everyone knows how to resolve an issue, so that real-time service recovery is extremely important as we engage with our nurses. Because we know their focus is to not only do rounds on a regular basis, but then to do the targeted rounds on those individuals who will be discharged, so the day before discharge as well as the day of discharge. And so that's certainly an opportunity for service recovery if there are items being highlighted at that time. Also, when we talk about the physician engagement, we've certainly been really excited about the leadership and their engagement around physician engagement. They have been working on a short training video that they're going to be expanding that to other physicians. We talk about it in our medical staff meeting in terms of the scores and the work that's being done. I specifically call it out of the work in my report to the executive medical staff meeting, and then also they're reinforcing the work at the staff meetings. So just jumping down to the process metric, and you see the boxes before you. Again, our two focus areas, doctor's domain and the nursing domain. A few things that they're focused on with our two key leads, Dr. Alanis and Dr. Ezekoli. Again, every patient encounter, including the name, their role, their clear plan of care, and asking questions so that there's clear communication between the physician and the patient. And that we saw as an opportunity as we looked at our scores. Also, they're developing, which they are super excited about, this new AI video where, you know, they can get all levels of physicians around the enforcing the always behaviors and then reinforcing that communication with patients. Also, we've seen some variation from floor to floor, and that's really why we want to hone in on the communication with our nurses and our nurse leaders. Tracking the meaningful, actionable comments. And before, when Ms. Dang was presenting, one of the things that they also have the ability to do is when they're talking to the patients, they have the ability to also connect with those support service areas. So in the iPad, there is a step where they can let our environmental services leadership know, as well as food and nutritional services, and we're adding some additional areas so that real time we can really hone in on that service recovery and real time correcting any issues that are highlighted. And then the last thing, again, they've revamping the staff training and making sure that 100% of the staff, as well as the support staff on the units, are trained. Let me pause there to see if there's questions.
Do you have patients that are, you know, the combination of physical and mental health conditions? Because there is training on de-escalation, and that really provides comfort to the clinician that's working, is having those skill sets.
Yes, and thank you for that question. You know, we see everyone, and we're proud to see all of our patients here at Stroger. And so the care team really identifies what are the support service areas that are going to be needed to help this patient as they go through the plan of care for the patient. So, yes, thank you for calling that out, and we do try to do that every single day.
Yeah, so we do have the de-escalation training. It's called the HEART with Cleveland Clinic, but also the hospital police does de-escalation too for the no violence zone area. So yeah, and then there was a simulation that they also do de-escalation training with the simulation lab. Yeah. Thank you.
And that can be scaled based on what each patient need, or?
Correct. Yeah. So those trainings are for the staff members, right? We could also provide with you a list of all a number, because I know that CMS is going to start requiring us to have a number of how many of the workplace violence that we have with the patients. But the de-escalation has helped a lot with helping our patients to calm down. And the training is truly for our staff as well, right? Because if their hackles are up and then yours come up, that's not a good case. So yeah, so we're learning how to calm down and take a step back.
So we have a tiered approach when it comes to training our staff on de-escalation techniques. Our staff members who are positioned in high-risk areas, like our ED staff members, our hospital police staff members get an intensive training program. It's a 3-day program, and it's a mandatory training that is repeated on an annual basis. Staff in clinical settings get a more condensed version that are conducted by our internal staff members. There are many trainers within our hospital police team as well as within our social work team. So we have internal programs that we offer to everybody, across the system. And then we have a little bit more intense, but not as extensive as the 3-day program for certain areas. If an issue comes up during our, root cause analysis or through internal assessments, then those staff members, as we work with the local leaders, we give them like a day-long training. We also have an online training module that is mandatory for anybody and everybody who works there, including our contractors. We have a workplace violence committee that tracks the numbers, all the events that happen here, and they have, strategies and measures based on the trends we see across the system.
Thank you. Because it's protecting the patients and it's protecting the staff too.
We do have a zero tolerance policy here. We have notices posted in all of the clinical areas that we will not tolerate that kind of behavior. So our staff knows how to have those conversations with the patients and, how to keep them safe as they try to de-escalate. Yes.
Thank you.
Thank you.
Thank you so much for that update.
Good morning.
Good morning.
Dr. Arnold Turner, Chief Hospital Executive, Providence Hospital, Cook County. Very happy to share the work that we're doing at Providence along the line of patient experience. At a previous meeting, we presented the Providence dashboard that showed several areas, domains that we'll be focusing on. The purpose of this is to improve our overall performance of our hospital. Our current rating is 53.77%, and our target is 67%. We're going to focus on 2 domains that were presented in the dashboard, the safety domain and the patient experience domain. What I want to share with you today is the activity of the Emergency Department Council on patient experience and looking at likelihood to recommend the emergency room for services. The target for that is 55.03%. In December, we're at 55.79. In January, we're at 44.57%. So we're not consistently above the goal. When the council met, there was a lot of enthusiasm and good conversation around how to improve the patient experience in the emergency room. And one of the things that they all agreed upon was that throughput has a lot to do with it. The time that someone spends in the emergency room definitely colors their experience. Even if they get good care and have a good outcome, if they're there for hours, seeing people come and go and all the other things that occur in the emergency room, the experience is not pleasant. So they really wanted to focus on improving the throughput. One of the metrics that I have been presenting to you in the previous years is left without being seen. We have been very successful in that and bringing it down from 11.72% in January 2025 to a full year where we were less than 2% and sometimes even less than 1%. And that definitely impacts our throughput. Nursing this year also took up a metric to also improve our throughput, and that's door to triage. In January 25, it was at 58 minutes. Our goal is to have it at 15 minutes. January of this year was down to 42. They instrumented some tactics now, and in April was down to 29 minutes. But the committee also, during this meeting, these are things that they were already doing in the emergency room before the council met. In the meeting, they also, in the discussion, identified another area that they wanted to focus on to drive our throughput even better and try to get it down to where we get more satisfying results on our surveys. The thing we want to focus on currently, let me just back up and say, the time that someone spends in our emergency room for someone who's seen from the door to that they actually discharge currently sits at 245 minutes. Goal there is to have it at 120. For someone coming in and having to be admitted, our year to date is at 505 minutes, and our goal is to have it 240 minutes. So we have some work to do. But what they looked at is another measure where there seems to be causing some bottleneck is at Providence, the hospitalists are the only physicians that have the privilege to admit. The ED physician can evaluate a patient and decide that a patient needs admission, but they have to consult with the hospitalist, and the hospitalist has to actually put the order in. So what they've seen is that the emergency physician will come to that decision, but there have instances have been delays in the hospitalist putting in that order or seeing the patient ED in the field. And as a result, that means the patient stays in the bay, blocks another patient from coming in. If they're there a long time, it just slows down the ED and affects the overall patient experience. Not only the patient who's being admitted still spending additional time, but the patient is being waited to be seen. So first is to get some data, actually establish a dashboard now that actually became available this week. And they're going to review that data. Want to make sure that the integrity of the data is sound. Looking at the dashboard, there may be some challenges there. But what the plan is then to put together a group with ED physicians and hospitalists and other key stakeholders in this to address this, to help move this forward. And be presenting that data to you in the future. However, one of the challenges that we have in Providence, since this is based on surveys, is our return survey rate is very low. And we've had a number of initiatives to try to move that, have not been successful. But I understand in the future there may be an email or other types of ways of contacting the patient for feedback. And I'll pause there for questions.
And the hospitalist has to approve the admission to the unit?
That's one way, but they have to accept and put the order in. Okay. Most of the times they do, but sometimes they don't. Make other recommendations before they admit the patient or arrange for outpatient follow-up, and sometimes transfer into Stroger for higher
So I was
care.
thinking, if a patient is an emergent condition,
right,
and they need to be admitted, waiting, 8 hours in the,
with most patients like that, I can say that they do come fairly quick as the others.
Okay.
Okay?
Okay.
All right. Thank you for that question.
And are there times that you're noticing that you're needing either checks or you're needing additional tests or lab work done before they can make that?
Sometimes they do come down to make that recommendation.
Okay. Yeah. And so those are things that may then hinge on slowing the delay. Right. Okay. On the throughput part. Okay.
Thank you.
All right. Thank you very much.
And if I could just interject, when it comes to the throughput, obviously, there's a lot that goes into the throughput. It's not just looking at your throughput numbers on a dashboard that's going to help us improve. And that's why I'm really pleased to hear you've heard the word council being used several times in these presentations, and that's reflecting the new structure within our quality department. Patient experience falls under that as well. And that structure includes forming councils at Providence Hospital by department. And each of those departments will then select, they're selecting throughput in the emergency room, what needs to be improved. They'll form a work group. That work group will include stakeholders, which another definition is frontline staff, to help us with those improvements. And what I'd like to see as we move forward in these presentations is more focus on that selection and deselection process, and what's the actual work being done at the front line, and how are they doing it? Are they being successful or are they not? And there's just something that we need to do as leadership and as the board to help them get that work done. And it takes a lot. That's what the whole Plan, Do, Study, Act is about, and it's really just bringing the scientific method to our front lines and asking them to help us improve. So that's hopefully, as we move forward in our presentations and quality, you'll see a lot more about councils and work groups and frontline staff.
When you mentioned that, I was going to ask about that Plan, Do, Study, Act. Are you using that collaborative practice then with especially the emergency department providers, the hospitalist providers, to see where there might be hiccups or delays in that care and the throughput, so that you can try to lower
Actually,
those
there's
rates?
a hospitalist representation on this ED council.
And you may need EBS.
Right, to
Right.
try to
About getting those
lower
beds
or
clean. It's
find
about a lot
out
of
what's
things.
happening
Right.
through that throughput, and, okay, this needs to happen first. Oh, wait, this has to be, this is
Correct.
taking a
That's the
delay.
study part, and that's what
Right.
Arnold was speaking about, getting the dashboard and really dissecting the entire process and finding out where is it that we're having the problems? Is it everywhere, or is it just in a few places? And then engaging those frontline staff and helping us improve.
Okay.
And that's what we really want to be coming and showing you all, less about the dashboard that are really hard to read, but I want to really get more about talking about what we're doing, what's the work that's being
Process.
done. Yeah.
The process. It'll be very interesting to see what continued work you're doing and helping in that way.
Thank you.
Oh, go ahead.
Makes me wonder, do you have people, resources to help investigate and do research around this? Because this is going to be a very good, learning experience for other hospitals.
Well, I love the question. We have resources that we're building out with Raji's help and with Amanda's help in BI or data. So obviously, a lot of this requires a lot of data and ability to kind of look at your data in different ways. And so, yes, but we are building that out. This is, I won't say it's relatively new to Cook County, but in a more systematic way, I think it is, and we're making sure that we engage those right resources. So it's taken some time to build out, but I really do think over time, this is going to be the way that we'll be sustainably improving our quality and safety here for our patients.
Thank you so much. We're not expecting a closed meeting in our session today, and so since we've exhausted.
still have,
We have
we do have
ACH.
ACH.
Well, please don't let me hurt. Sorry. Who's number? Oh, that's what, okay. Oh, my goodness, yeah, okay.
Good morning. I'm Cherie Boyd. I'm the Chief Operating Officer for ACHN. We're here today to discuss our Plan, Do, Study Act for patient experience. I have Claudia Burshinow, who is my Executive Director for Primary Care, to present.
Good morning, everyone. Claudia Burchino. Thank you, Cherie. That is one. And it's a little large, so it's 2 pages, so thank you. So just to give a little background, last year we initiated a task force to improve patient experience, key drivers about staff working well together, and 2 others. And we realized that patient satisfaction and employee engagement are closely connected. When when you recognize the work and you value the staff, you can see the positive impact in the work that they contribute with the care for patients. So we decided our improvement for this year, and the plan is to improve the patient satisfaction and the engagement employment for ACHN. So through the Thriving Together session that was presented last time, this took place back in October. We gave the opportunity to all our staff in ACHN to join this forum. We listened to them. We came prepared with a set of questions. Through also employee engagement results, through patient experience roundings that we did in a couple of months, and interestingly, a secret shopper patient visit. We had somebody who went and pretended to be a patient from start to end in different clinics. And it was really interesting because we discovered that there were gaps in communication, there were care coordination visibility, lack of care coordination visibility, and also lack of awareness from the staff of the different resources available for them. So, and this happened across 30 ambulatory sites. We did it for the entire ACHN. And we also identified one of the biggest things was the staff recognition was inconsistent across all the clinics. And so that we identified this in FY26 as our primary priority in ambulatory. So our goal is by the end of this year, if you look into the square of the plan, by the end of this year, our goal is to improve the Press Ganey top box score for staff work together, providing care to you, by a 2.18% increase compared to the baseline from FY25 that was at 67.32, and that is our goal, to aim for that. We are going to be doing this through one structured initiative, which is the ACE Reward or Recognition Program. So ACE stands for Ambulatory Champions of Excellence, right? We definitely determined that recognition and the staff feeling valued was key. So the purpose of this program is to celebrate the staff who exemplified the behaviors and contribution that support exceptional patient care. And remember, what gets recognized gets repeated, right? So we want to make sure that this program, we are constantly recognizing those individuals for those excellent standards of behaviors and commitment that are aligned with CCH standards, and we can recognize them and definitely help to build that culture we want to see across our system. So with that said, what have we done in the last year? So as I mentioned before, this has been a phased plan. One, we started with the discovery phase where we identified these gaps, right? Through the Thriving Together listening sessions, through this patient experience rounding. So being there in the Gemba helped us understand what was truly happening. Becoming that secret shopper patient was excellent. The second phase was the program inception and planning, when we started to review this employee engagement surveys results. And through the Thriving Together session, that was the #1 response that we heard from our employees. I don't feel recognized, I don't feel for the work I do every day, and that was very important for them. So that second phase was that program inception. In this program, the architecture of this program is tiered rewards. So we're going to be rewarding patients on a monthly basis, staff on a monthly basis, a quarterly basis, and an annual basis. The beautiful thing is not only the employee, it's also going to be the clinic itself on the annual basis. What type of recognition we're going to offer? We're going to be displaying this in our newsletter award. We have created a newsletter that is going out next week. And we're going to have there the first person who made for this month of May, the employee of the month, pretty much recognized for their excellent behavior and contribution through their work. Of course, we had, and I skipped the phase 4, but phase 3 was making sure that this program that we had put in place was compliant. And so we had to submit it to legal department, the legal team, corporate compliance, and of course HR to understand who would be eligible for this program and what we could do, what kind of rewards or recognitions could be provided. So we're gonna be doing trophies, we're gonna be doing certificates, we're gonna be doing recognitions and spreading the word. We even thought about inviting someone to CCH Gala, or why not the foundation, right? And feeling valued and appreciated for the work they're doing. Last but not least, we go live next Tuesday. That's when we launch the program. So we're very excited. Finally, we see the fruits of all the work we've been doing, and this is gonna be that will continue done on a monthly basis, quarterly basis, and annual basis. So what is the study? The study is we need to make sure we're tracking the progress. Is this the right way to go? So the two measures, the two primary outcome measures are gonna be one, the Press-Ganey top box score for staff working well together. And we track this on a monthly basis in ACHN, and not only overall, but also by the individual clinic. So that's one. And then two, we're also gonna utilize the employee survey with which is a key driver. The organization treats the employee with respect. That's one of the questions that comes up. And that's one of the questions we scored very low. So that's gonna be the second measure. This employee survey takes place on an annual basis. So we're gonna see this improvement year after year. Our process metric, so there is an app that is called Pulse Point that you can send kudos or recognitions to everyone. We started using this in December. So if we can go to the next slide, please, just to show the graph. And it's the tiny graph dashboard at the top. There's an association between the staff recognition, that we call that kudos, and the patient perceived teamwork. It's really interesting. If you see in the month of December, a high number of recognition and kudos were sent out to the staff, right? We were reinforcing and continue to reinforce in leadership. Let's make sure we're recognizing everyone, our managers, everyone. In that month, the score for how the staff work well together went high. When we didn't do that in the month of January, went down those kudos, the percentage, the score went down as well. So we see the relation in between these two. So the Pulse Point is going to become the leader outcome measure, the process measure, to determine, right, who will be that employee of the month. Of course, there's other criteria that are going to be in place or that are already in place to select that employee. And then next, which is not last, is what are we acting on, or how are we adjusting? Well, we need to see how this goes, right? And once we start seeing that progress and track that, we will make sure we do adjustments as we go to make sure we are fully successful. I am concluded with my presentation, but I'm open to recommendations and to any questions that you may have.
Love the secret shopper.
Oh, you should have seen at the end, in their secret shopper was our Centers of Excellence manager. Nobody knew she was hired. Nobody knew even she started. So she scheduled the appointment, went to see the provider, got through registration, waiting area, intake, everything. Very interesting. We have a page, a report back this big, which is really valuable for us to see those areas we need to focus.
Yeah, just want to share, we did do a secret shopper for Stroger as well.
It'll be interesting to find
share.
out.
Yeah,
what
we have the
lessons
results,
learned.
and the interesting is the person who went in, his name is Adonis, and we told him to call yourself Athena to see if the staff, use your preferred name. And so he is, they did use his preferred name, but then the text that sent him the appointment didn't. So there's a lot of opportunities to improve, but he told us he had a good experience, so that was really good to know, yeah. But they too did not know who he was, yeah.
Thank you.
We look forward to the updates from that,
Just-
yeah.
And just one thing, I'd like to make sure everyone, this may be Cherie Boyd's first time that you have all met Cherie. She's new to Cook County. She's the Chief Operating Officer over ACHN. So,
Great, thank you. Yeah.
So I work with Cherie.
Okay. Thank you, Cherie.
Thank you.
Thank you so much.
Somebody's online.
Okay, Manny Estrada, I believe you are next. Sir Mac?
Yes. Good morning.
Go ahead, please.
So you can begin, Manny?
Yes, ma'am. Good morning, and thank you for the opportunity to present our work related to patient experience. I'm here to present our work on the patient satisfaction survey that we have going on with Juvenile Detention Center. It's important to note that we've always had a patient satisfaction survey at the Juvenile Detention Center. It is absolutely unique in a correctional experience to try to gauge the satisfaction with healthcare. But nonetheless, it's something that we've undertaken in the Juvenile Detention Center. Our goal is to do this. We formerly did it 2 times a year. We're increasing that to cycle out at once a month. The process will include for us to do approximately 10% of the patient population. For the purposes of numbers, our census runs roughly at about 200. That's our average daily census. We'll be breaking up the population into 2 cohorts. The first being those that are under 30 days, and the second one being those that are over 30 days. For us, it's important to gauge both. We have the situation where most of our patients get admitted and cycle through in a relatively short period of time. So it's important to gauge those that are longer term versus those that are more short-term patients. Historically, what we've done with the patient satisfaction survey is we've gone to the patient in the school setting. They have a public school in the Juvenile Detention Center. We try to do the satisfaction survey in the non-clinical area to try to make it as unbiased as possible. Formerly, what we had was one of our staff persons sit with the individual and go through the survey in itself. We're introducing technology into our process. Not only are we going to be doing it once a month, but we're going to be introducing tablets that allow the youth to be able to fill out the survey themselves. We hope that this provides for a sense of being able to do it unbiasedly with our folks having any input into the survey in itself. This is the first month that we've begun to do it once a month. We expect this to happen moving forward on a monthly basis to be able to gauge where we are. Our preliminary results are positive. We are at a 9.3 out of a 10 for those, 9.6 out of those that are over 30 days and a 9.3 for those that are under 30 days. The survey in itself is about 15 questions. They're done in conjunction, like I referenced earlier, with some of our collegial staff in the Juvenile Detention Center. It is done in the public school setting with corrections actively involved and engaged, not only in the assistance for collecting the information, but also with the review of the information. The survey in itself is geared towards medical services because we are in a custodial setting. We don't really want to delve into other areas that are beyond our control. We do report out if there's anything that does come up. For example, the environment, if there's something that our patients are referring to, we do share with our DOC colleagues and or our facility colleagues, depending on where the situation is. Really proud of the work that we're doing here with patient satisfaction survey. Again, it's one of the most unique aspects of patient experience that I've had the opportunity to work with in a correctional setting. And it's important to note that this is done with our youth. We currently do not have something like this at CERMAC, and it's not prevalent in the adult population. So it's, again, something that we're really proud of. We'll continue to monitor this moving forward on a monthly basis, and we look forward to incorporating that feedback to address any issues that our clients, our patients have brought to our attention. I'll open it up for any questions that anyone may have, but we look forward to continuing this, and thank you for your support in continuing this initiative.
Thank you.
Just, do you have any plans to do it in the Cook County Jail setting, Mr. Mayor?
The short answer is no. We've kind of walked through the process to determine what would it look like. We have a daily census of about 6,000 at the jail. Just the volume would be difficult, but the reality is there's a process we already have in place to kind of gauge what happens in the adult facility. It's called a grievance process. It's a little bit more aligned with DOC requirements, but it's partially built in to capture some of our information. Without getting into too much, it's a little bit more difficult with the adult population for a variety of reasons, but we've already kind of vetted and passed this through compliance and risk, and it's something that I think we're going to have to struggle with doing in the adult side.
What can you use to accommodate or to give you some type of feedback for adult level services related to that, since we won't be able to gauge them directly?
We do. We actually have a process. I referenced the grievance process. That's a codified procedure for our adult population to be able to, as they want to, be able to provide feedback to us. It goes beyond just the medical realm. It does go into the custodial and to the facility-related issues. It's a really robust program. It's a requirement that's in place. We do that daily. We report out monthly. It's something that is one of our key performance indicators that we have in a different component of our quality plan.
When you reference medical, does that include behavioral health as well as physical?
Yes.
Okay,
Yes.
thank
I apologize. Let me provide a little clarity. On the juvenile detention side, we have a really robust behavioral health component. The ratio to behavioral health professional to patient is an incredible ratio. On the adult side, and this presentation is not for the adult side, but we also have a really robust behavioral health service line in both of the areas. Really proud of the work we do there. And as an aside, our accrediting body, which is the National Commission on Correctional Healthcare, has 3 accreditation status. One is the regular jail standard. We're compliant and we're accredited on both the juvenile and the adult side. They have an OTP, an opioid treatment accreditation. We are accredited on the adult side. There is no OTP for the juvenile side yet. And the 3rd accreditation is mental health. We are slated to be surveyed, hopefully 4th quarter this year, to achieve all 3 accreditations. All 3 accreditations aligns the organization to be in line to be able to receive it's called the Pinnacle Award. There are very few organizations in the country, correctional health organizations, that have achieved that level of success. Our hope and our plan is to be able to achieve that, if not 4th quarter this year, 1st quarter the next year, depending on when the accrediting body can come through.
Thank you. Thank you. It's an important service that you provide, and I have been a guest speaker at the Juvenile Detention Center, and I'll tell you, my heart goes out for people that work there and support the youth. It's really a great program. Thank you.
Thank you. No, thank you.
County Care.
Next up, we've got County Care, and Aaron is remote. Oh, I'm sorry. Wrong verse.
Good morning. My name is Emily Lupo. I'm the Director of Population Health and Performance Improvement at County Care, and I'll be providing an update on County Care's member experience. County Care uses the annual CAP survey as our primary mechanism for tracking member experience
The CAP survey is administered each year, and what you're seeing reflected here is our analysis of results from 2025. What I'd like to highlight is that we had some strengths, which were that County Care was the only Illinois plan to receive a 4.5-star member experience rating in 2025. And we also received a 5-star rating for rating of a health plan, which means we achieved scores above the 90th percentile. We also identified some areas for improvement, including getting care easily and getting care quickly. Member experiences in these categories really reflect a County Care member's experience in accessing primary behavioral and specialty care within our network, as well as accessing care when they have an urgent need. And so what you're seeing in the do box of this template is really the work that our member experience work group and quality improvement committee have done over the last year to address those findings and to build on the strengths. So I'll talk a little bit about that as well. We do root cause analysis, and our work group designs interventions that are really strategically identified to address those areas of opportunity. So you're seeing interventions from the past year in 3 buckets. The first was a 2026 CAPS campaign. The goal of that sort of marketing and communications campaign was really to encourage member completion of the survey. We want member feedback. We want to hear from them. We use that information to really inform changes. The second was really to drive awareness with members and connect the dots that we have made changes from the prior year based on their feedback, and sort of highlighting some of the quality strengths that County Care brings as a health plan. The second area of intervention is really related to member outreach and engagement. We've made several enhancements to the member portal, making it easier for members to access information that would help ease them in getting the care that they need, or accessing care reminders, insurance information, etc. We also have been working collaboratively with providers in our network to expand community events, trying to include health maintenance services, including immunizations, cancer screenings, blood pressure checks, and things like that at already scheduled redetermination or community events that we participate in. And then lastly, in this group of interventions, we have a lot of direct member outreach that we've continued to build upon in the past year. This includes text message reminders with links to where they can access care. We've continued to develop member education materials and then do more direct outreach to members, including direct call campaigns, and working with our care management and provider partners to facilitate some of that outreach as well. And then lastly, we know providers are really important in driving improved access to care, and so there's been a number of interventions in the provider engagement and network bucket that I wanted to highlight. First, we continue to work with partners in active partnership. We regularly engage with providers in our network through strategic partnership review meetings. We share some of this member feedback as well as quality scores and work with them collaboratively to address barriers. Additionally, we've worked really hard to do continuous improvement to our Find a Provider tool on our website, making things like filtering easier, so if a member goes there, they can find the specific type of provider they're looking for. And then we've prioritized adding more behavioral health and primary care providers to our network specifically. Those were specific root causes that came up in the 2025 feedback, and so that our contracting team has really taken that seriously and has prioritized those additions to the network. And then lastly, we use provider incentives broadly to really align with access and quality outcomes that we want to promote. We currently are closing out our 2026 survey, and so the next step in our quality improvement process related to member experience will be doing a comprehensive analysis of the 2026 results doing root cause analysis and follow-up on findings, and then beginning the annual cycle again, designing interventions that really speak to the 2026 results. And so I'll look forward to reporting out on those at a future meeting once we have the 2026 results in hand. What you're seeing on the bottom in the process metrics section are really how we've been measuring and evaluating success with what we implemented this last year. And that would include tracking media results, looking at CAHPS results through different segmented views, including age, gender, language, and race ethnic groups, as well as doing a little bit deeper dive into some of the category ratings. And then we do regularly track internally also member engagement with some of the tools that I spoke to, as well as network adequacy reporting overall.
I just want to say, I think the recruitment, as you said, for a primary care and behavioral health specialist is very challenging.
Yes.
I mean, it's across, you know, Illinois. It's challenging. There was something in New Hampshire that they had the same issues. They really are struggling with getting people in, but they created a network of, and it's New Hampshire, it's a little bit smaller, but they created a network so that everyone, behavioral health specialists, apply to it. They're included. They have to write down who, you know, what health plans they're associated with and what their specialty is. And then the patients, upon having a first-time visit, can then go, and the parents can go and look for clinicians that they want to meet with. So I think technology may be a way of helping out, because it is, I think everyone's struggling with behavioral health.
Thanks for sharing that. We will definitely look at that and see if we can leverage some of the learnings of that.
Yeah, it was amazing to see. I mean, it was a all-out effort by New Hampshire.
That's great.
Yeah.
I think in the meantime, too, recognizing the CAHPS score of a 4.5 star and a 5-star rating for the health plan, and that those were the only ratings for the state, is something to be for recognition as well, too. So congratulations very much so towards that as well.
Thank you. It's certainly a whole plan effort, and I think we as a plan also recognize our partners play a big role in that as well. So we're very proud of those results.
That is great. That is great.
Thank you.
Thank you very much. I think our last item is our performance improvement update, which will be reviewed by the Chief Hospital Executive for Stroger Hospital, Donica Austin Kathy.
Hello again. I'm going to ask Andrea to just high level share the 2 PI projects that we've been working on at Stroger, and then we'll certainly open it up for questions.
Good morning, everyone. I'm Andrea Rammel, Director of Performance Improvement. The first slide, we wanted to provide the board with an overview of our process improvement plan for the system in 2026. And it's really centered around our purpose of developing our leaders to be coaches of process and continuous improvement, and empowering our team members to be problem solvers and improve the work that they do every day. And so within our action plan, we have a number of items to help us achieve that purpose. The first 2 really focus on standardization around our terminology and how we provide training. We also have a training that we've brought in-house for our leaders, and we want to augment that training with cohorts post-training so that our leaders have an opportunity to be coached while they apply what they've learned. We want to really align our resources across the system, establish an oversight committee, and identify a couple model cells to test some of our improvement work. If we go to the next slide, We have a couple of, projects that we want to highlight. The first was an arrhythmia escalation workshop. And I was really proud of this group of frontline team members, frontline night shift team members, that came together, really under the, thought that the current process, you know, left our patients vulnerable. And they wanted to take ownership and improve that process. So we did, an analysis of current state, identified gaps and waste, went through some exercises to get to root cause, and then developed an action plan based on those root causes. And you can see a picture of the team up there. And the next steps are really, you know, revising our policy and creating a guideline. And we want to do that ensuring that we have subject matter experts, physicians, leaders, and frontline team members involved in creating that. And then there's also a component of ensuring appropriate functioning of our equipment. The next, if we go to the next slide, the next project that we wanted to highlight, I think the board has heard quite a bit about in terms of how it impacts the work we do around care for patients with sepsis. But we successfully implemented some technology called Soft ID in the emergency department, which allows our nurses to real-time document the collection of blood cultures. Again, this was an amazing project that really the front line came together and said, we want to do better, we know we should be doing better, and really took ownership. And one of my favorite things about this work is on that graph, on the first day that this went go live, there was 87% compliance with the new process. And to me, that really shows that this was something that was driven by the team to have that level of adoption really at the beginning. So now that is in the stage of sustainment, and they're following those compliance metrics. You know, taking reasons why they're not collecting the blood cultures via Soft ID, creating a Pareto chart, and then really getting to root cause. But super proud of that team and their adoption of the new process. Any questions?
And that will help so many patients.
Oh,
yes. Yeah, really does.
So Andrea, I do have a question. Can you go back one slide?
Yes.
Can you tell us, in the picture of those frontline staff, are there physicians involved? Who's involved in that picture?
Yeah, absolutely. So there's a gentleman on the left with like a suit coat on. He is our chief resident. And he came in and participated again because, you know, the event that we were looking to improve happened in the night. We involved the night shift, and we actually held this event overnight. And so we had a chief resident. We had 2 of our telemetry technicians. We had night shift nurses. We had someone from GE come in during the night. We had some of our clinical nurse leaders, and then an operational leader. So just a great, great group of folks who we fed them a lot of caffeine, and we got a lot of good work done.
I bring that up just to kind of underscore, this is the work that I want to bring to the board. Mm-hmm. This is what I want you to see and what we're doing. And I also want to point out that how engaging that is to our employees, to have every level of employee within the organization banding together to solve the problem. You have all the way from physicians to telemetry techs, varying degrees of education, varying degrees of background coming together to solve these problems. And that's exactly what we want to do, and what we're going to try to present at this meeting more often.
Particularly at the timestamp of when these incidents are occurring, so we can have the best intervention opportunities. Thank you so much.
Thank you. I think this has been a great meeting.
Mm-hmm.
And again, I congratulate all of you for all the work you're doing, because it's, you know, it's again, your professional experience, your skill sets, your passion for what you're doing, but it results in good outcomes for the patients and the experience. So again, thank you. This is a tremendous amount of work, but it's paying off. It is paying off. Thank you.
Thank you for those comments. We appreciate that. Thank you.
We we appreciate the work that you did in putting this all together.
Yes.
Although it took a little bit for us to keep up with everything, we were able to see the improvements that you're doing and what you're doing in patient care. So, thank you very much.
Thank
you. All right. Since we are now exhausted, we, hereby declare this meeting adjourned.
Thank you. Thank you.